everyone. My name is Jasmine Patel, and I serve as the Director of Policy and Outreach for the Partnership to Advance Cardiovascular Health, also known as PACH. PACH is a stakeholder coalition dedicated to cardiovascular health and innovation. We work to galvanize the patient and provider community around public policies that increase access to patient-centered care for cardiovascular patients. As a precursor to this webinar, when the COVID-19 public health emergency was declared, PACH collaboratively explored its effect on cardiovascular and diabetes care. We virtually convened a diverse group of healthcare providers, patients, and representatives of advocacy groups, policy organizations, and scientific associations in a series of discussions. What was really unique about these calls is that they were happening in real time. We were discussing patient care with patients, providers, and organizations, while policy changes to address COVID-19 were being pushed through the healthcare system via the CARES Act and Centers for Medicare and Medicaid Services waivers. These conversations are summed up in our recent report titled Pandemic Lessons: What the COVID-19 Emergency Has Taught Us About America's Healthcare System. You can find this report on PACH's website, advancedcardiohealth.org, and it will be emailed to those who registered for today's webinar. Without a doubt, COVID-19 shook the US healthcare system to its core, laid bare its vulnerabilities, but also accelerated some innovations. We convened this webinar because we believe it's critical that patients, providers, and the policymaking community take a hard look at what is happening and what has happened previously. Today, we have brought together an esteemed group of clinicians who are not only leaders in their field, but also fierce advocates for public policy that supports patient-centered care. Our speakers will participate in 3 panels to discuss the central issues highlighted in our report. First, we will talk about continuity of care and telemedicine. Second, what the pandemic revealed about America's racial disparities. And third, we will cover utilization management challenges during the pandemic. It's important to recognize that the lessons drawn from these discussions and outlined in our report apply to the cardiometabolic community, but we also hope that they apply to chronic disease care in general and challenge us to think about policy solutions that can improve America's health. In order to give our panelists maximum time, we will not have an audience Q&A session. However, we will be engaging the audience on Twitter. So if you do have a Twitter account, please tweet us and send us your questions at Advanced Cardio Health. You can also tweet using the hashtag HeartLessons. A lot has happened over the last 7 months, but we want to pause for a moment and look back on the initial emergency period and the upheaval that it has created for patients with cardiometabolic disease. We need to ask the difficult questions. We need to recognize who has suffered the most during this disruption and why. We need to ask ourselves why we haven't embraced innovations that are now standard course of care. And we need to identify opportunities for advocacy where it makes sense. The central question we aim to answer today is, what has COVID-19 and our response to it taught us about patient-centered care in the United States for those with cardiometabolic diseases? To begin our first panel on continuity of care and the promise of telemedicine, I'd like to welcome Dr. David Charles, Chairman of the Alliance for Patient Access. Dr. Charles, welcome.
Jasmine, thank you. Hello, I'm David Charles. I serve as chairman of the Alliance for Patient Access. My practice is at Vanderbilt University in Nashville, Tennessee, where I also serve as medical director of telehealth. So according to the CDC, in the periods of March and April, kind of really during the height of the lockdown, we saw deaths from cardiovascular disease in the United States skyrocket by 27%. Yet at the same time, emergency room visits across the US fell by 23%. The New York Times ran an op-ed by a cardiologist entitled, "Where Have All the Heart Attacks Gone?" The reality we know is that patients didn't stop having heart attacks or stop having strokes. In fact, they continued. They just stayed at home while having them, and many died at home. So I really think it highlights the importance of the management of chronic disease and comorbidities related to those diseases, even during the time of pandemic. Meanwhile, at the same time, we've seen a paradigm shift in attitudes toward telehealth, and this has revolutionized the way we're going to deliver healthcare in the future. So with us today, have Dr. Larry Sperling, who is Director of Preventive Cardiology at Emory University, and Dr. Amit Kara, who is Director of Preventive Cardiology at the University of Texas Southwestern. To get us started, let's talk about the latest data on cardiovascular disease and comorbidities related to COVID. Dr. Sperling, I'll call on you first. What is the current COVID-19 data telling us about cardiovascular disease? And is there anything in that data that's surprising to you?
Thank you very much. I'm glad to join the webinar today. In terms of our current data, what we know is globally, there have been over 20 million individuals who have been impacted and affected by COVID-related disease, 5 million in the US, and over 160,000 individuals have died of COVID-related illness to date in the US. These data are likely an underestimation of the impact of this intersection between a viral illness and what appears to be vulnerable populations. In the US, we have data from an MMWR published in June, and this MMWR points out that those living with serious health conditions like cardiovascular disease, diabetes, and COPD, they are at 6 times greater rate of being hospitalized from COVID, 5 times greater rate of being admitted to the ICU, and a 12 times greater rate of dying from this viral illness. As far as this being a surprise, unfortunately, it is not a surprise. What we are seeing, again, is the intersection between a vulnerable substrate and a novel viral illness.
Thank you. Dr. Kara, during the months of March and April, when it was really kind of at the height, hospitals reported that they had a 40% drop in patients presenting with heart attack. As a cardiologist who's worked closely with patients, what were you seeing in your facilities?
Well, thank you, and it's great to be with you and my longtime friend, Larry Sperling. Let me say, this is a public health emergency, and certainly what we're seeing is a drop in people presenting to the hospital. First, we count emergency room visits, and we certainly saw, you quoted those numbers of decreased presentation for heart attacks and strokes. Every place in the country is different. In New York, obviously, people were inundated. I'll tell you, here in Dallas, we had a dichotomy. We have the COVID ward with incredibly sick patients, but the rest of the hospital was quite empty, and it was almost eerie in a way because patients weren't coming in and were quite fearful. And that obviously had us concerned for what we're seeing now, which is this scourge of preventable heart attacks and strokes that are showing their head now.
Thank you. Dr. Sperling, most people with kind of chronic conditions, cardiovascular disease and such, they may not view missing the occasional appointment as being particularly problematic, especially if they're not having symptoms. And I'm sure that they don't think missing the occasional appointment could lead to death. But we see this now. How vulnerable are these patients with cardiovascular disease? For someone who isn't a doctor, how would you describe the type of people who are dying from the loss of follow-up and continuity of care?
I've been asked this question many times by my patients in terms of the spectrum of risk related to COVID. We do know that age, presence of underlying chronic diseases, and likely health disparities, social determinants of health, are playing out in terms of risk. Related to missing clinic visits, I don't think we fully really understand what the long-standing implications will be of this pandemic. Clearly, there are intersecting issues, people not coming into emergency rooms, individuals not showing up for their follow-up care or presenting to their usual clinical spaces. We know from just general times when there's not a pandemic that continuity of care matters. It actually predicts outcomes in those with chronic diseases, as does adherence to medications. So right now, I think we don't know really what is happening underneath this pandemic, but I think the consequences will be concerning.
Yeah, agree. Dr. Kara, I know in caring for my patients with chronic disease that follow-up appointments can often be very challenging. Missed work, travel, and such as that. With the pandemic causing even more difficulty with patient compliance with visits, has it changed the way you communicate the importance of compliance to your patients, to your colleagues, to medical students, even health plans?
Yeah, thanks for that. And I want to pick up on what Dr. Sperling was just mentioning. And it comes to the crux of, what do we know about these routine visits? We're also used to them now that you see your doctor every 6 months or a year. And, what's the value of that? And I think COVID for me has made me really dissect that a little bit. What is accomplished in those visits and how is it helping people? And I just want to say a few things. First is medications and adherence. When we think about medications, people need refills, right? They need to know the value of that. Lots of times people run out, and that visit is a time to make sure they're getting those pills. They can afford them. People are losing their jobs and so forth. The second part is checking on symptoms. A lot of people have symptoms and they wait to their doctor's visit to mention them, and they may be quite important ones. The third thing is lifestyle, checking in on physical activity and nutrition. That's really important. And there's something in COVID that I've noticed a lot, which is reminding patients. There was a New England Journal article, they did a qualitative survey. Patients hearing from their doctor that the hospital's safe and that they should come in if they're having symptoms, that actually carries a lot of weight. And I make a point at every visit to say that. Make sure that if you're having symptoms, the hospital's safe, you need to get attention for care. So I think all those things are important in these continuity visits.
Yeah, agreed. Dr. Sperling, anything to add there?
Yeah, I want to echo what Dr. Kara said about mentioning to your patients about safety. I think safety and trust are paramount right now. I've been using a quote frequently in many different forums. It's from Albert Einstein, and it says that in the midst of difficulty, there are opportunities. And I think right now, although we have challenges like we've never had before, these are unprecedented times. I think we are learning about some unique opportunities to deliver healthcare in ways that have been possible before, but now we're really charging ahead with new care models and the new future of medicine and hopefully cardiovascular prevention.
Yeah, I couldn't agree with you more. As a medical director of telehealth, many physicians and clinicians have managed to continue care of their patients through telehealth. Once the public health emergency and the national emergencies were declared, social distancing was imposed, and many hospitals and facilities completely closed down. Elective visits, elective procedures, and the hospitals cleared out. We saw at our institution an incredibly intense focus on telehealth. Therefore, I think it's kind of important that we highlight exactly what changed as far as policy toward telehealth in the United States. So once the public health emergency was declared, the administration took several steps to allow telehealth to really flourish in the United States, knocking down several barriers that had been in place for years, impeding Americans having access to telehealth. The CARES Act allowed 80 codes to be billed at the same level as an in-person visit for a telehealth visit. Audio visits were included as well as audio-visual in the more traditional form of telehealth. The CARES Act waived co-payments for telehealth visits for many people. And it should be noted that these policies have been extended for another 90 days. As a result of my experience at Vanderbilt, the uptake has been absolutely incredible. So I've served in this role now 6 years as director of telehealth. And in about 8 days after the public health emergency was declared and the administration really knocked down the barriers keeping patients from having access to telehealth, we went to about 2,000 to 3,000 visits per day at our institution. And that's more than we did in the entire prior year in telehealth. So that just, for our telehealth team just represents a remarkable revolution in healthcare. So Dr. Kara and Dr. Sperling, what was the uptake like at your institutions? And what are you hearing from your colleagues at other institutions?
Go ahead, Larry.
You want to comment first?
Oh, sure. I'll comment first. First, similar to you, we were doing telehealth. We had started, it was largely in small domains and niche areas. And the uptake has been profound. I think we will have a lot of learnings. And I'm very thankful for the CARES Act that facilitated telehealth. And I'm sure we'll get into this, but it's really been a game changer, something we really needed for a long time. Our uptake has been phenomenal. Currently, I'm 50% telehealth. I'm back to full speed in all my clinics. And not only currently, but building out to the future, currently building out to about 50% also. And similarly with many of my colleagues, maybe not quite that high, but high proportion of our patients being telehealth. So it's really had a rapid uptake. It's amazing how fast all of our institutions have had to pivot to this. But at the same token, it shows you how fast we could do it. It has happened, frankly, across the country.
Yes.
Yes, similarly at Emory, we had an explosion in our cardiovascular team utilizing telemedicine and telehealth services. We have embraced it. I think our patients welcome this opportunity to make what I call a modern day house call. It's actually wonderful to visit our patients, and the dynamic is they're in their home environment, and we get a chance to really learn about what's going on with them, but often including family members. There can be clues to what's going on with them, not only by others and their family contributing information, but looking at their home environment, which we're not privy to normally in a clinic visit. And so telemedicine is absolutely here to stay. I think this is one of the silver linings we will see from the COVID pandemic.
Agreed. Dr. Carroll, I'll come back to you. What's been your personal experience in conducting telehealth visits? I mean, what would you say are the pros and the cons of it? And maybe shed some light on your opinion about when it's appropriate or when it's not appropriate for your patients.
You know, I've absolutely loved it. And I say that because I'm so happy to be able to access my patients, for them to see us and get the care they need. A lot of what was worrying during COVID was that I know patients that we're seeing regularly have issues and are just not getting care. And that worries us all as people, responsible for them. Secondly, as Dr. Sperling pointed out, there's so many little nuances there. The part about it is so relaxed. The clinic visit is very sterile. They're in your home court, and it changes the dynamic. When you're in their home, and frankly, sometimes I'm doing it in my home, that's happened, it's a very different visit. It's very more relaxed. There's no difference in how we do the mental processing and what we cover, but it's just a very different environment, and the way we engage is a little bit different. And as Dr. Sperling mentioned, I absolutely love, it is so common to have a family member on screen or sometimes sitting right next to it. You see the patient turning their head because they're getting cues from the family member. But, health is a family affair. It's not a personal affair. So I've absolutely enjoyed it and look forward to continue doing it.
Yeah, I would say, at Vanderbilt, I think just during the COVID period, we've done close to 150,000 telehealth visits. So thousands of patients in our catchment area have had this experience. And that's replicated across the entire United States. Now, millions and millions of Americans have experienced telehealth, where in the past, policy really prevented many people from gaining access to telehealth. So let me ask you, Dr. Sperling, what do you think the downsides are to telehealth? I mean, is it going to replace in-person care?
I don't think telemedicine or telehealth will ever replace in-person care. Getting back to being patient-centered, I think right now, because of the concerns that so many of our patients have, we really need to ask them what they're comfortable with. And so if they're comfortable with a telemedicine or telehealth visit versus in the office, we should be deferring to them. Now, there are patients who are having acute and very concerning medical problems. These are people that don't necessarily need to be encountered through telehealth. These people either need to come to the emergency room, and I have absolutely found that seeing patients in the office, being able to do a detailed physical examination is critically important still. I'll mention a paper that's about to be published in the American Journal of Medicine by Neil Stone and others from Northwestern, but it's called the Telehealth 10. And I think we'll have a learning curve about how to better examine our patients. Like Sherlock Holmes, we will be wonderful observers, but we can ask our patients to help us with a home-based physical exam using lighting, for instance, to see the neck veins or a corneal arcus. So I think the physical exam, we have to learn better how to do that. And then clearly right now, there are still going to be disparities in the ability to deliver telehealth services, and we don't want to widen what's called this digital divide.
Agreed. And maybe on that, we'll begin to wrap up our session. There have been lots of barriers to the adoption of telehealth, but let's focus on the barriers really now for our patients. And you spoke about the digital divide. So to use telehealth from the patient's perspective, if you're doing a direct-to-home visit, the patient technology to do it? Do they have a smartphone with audio-visual capabilities, or a tablet, or a computer? Do they have high-speed internet? And then do they have the technology literacy to be able to use those devices to reach their physician or the clinicians? I think it's important to note that of people over the age of 65, 1/3 of those don't have high-speed internet connectivity in their home and may not use the internet, in fact. And then another very troubling fact, nearly half of Americans that don't have high-speed internet connectivity in their home are from Black or Hispanic households. And so, Dr. Sperling and Dr. Kara both, how can the public health system kind of address this digital divide?
Yeah, I think we need to be addressing the digital divide through all sectors, certainly through public health, but through usual delivery of healthcare, through workplaces, through tutorials and coaching. What we want to do is strive for digital health equity. And I'm hopeful that it will be one of the lessons that we learn from our current pandemic. The opportunities we have in front of us is to say we can deliver telemedicine and telehealth services in rural communities. But we need to understand that 24 million Americans do not have broadband access. And so part of this digital health equity is having the technology available, the skills available, and really, I think if we're able to do this, we will open up new possibilities in healthcare.
And I'll just pick up on that. I want to maybe finish where we started. And Dr. Sperling was telling us about how this COVID pandemic has laid bare inequities in our society, and that has allowed this to ravage from a cardiovascular disease standpoint, and really on the backbone of problems with social determinants of health. There's a societal component where we have to, again, in terms of equity, ensure all the necessary components as it relates to social determinants of health, and try to get broadband more expanded, make sure people have socioeconomic security, all of those things. And then simultaneously, I do think they're technologic things. You don't need broadband and a fancy computer and all that. There's really easy ways to do it on smartphones as well. So we need to simplify in some ways also and make things much more accessible. But we definitely have to close that digital divide so we don't exacerbate disparities.
Well, it's certainly been a remarkable experience for us here at Vanderbilt, and I want to thank both of you for joining today's panel and trying to advocate for telehealth. Physicians and other clinicians aren't known to be early adopters of technology always, but I think the swift uptake of telemedicine during this time clearly demonstrates that our healthcare system is adaptable. So long as we have the right policies in place, we have clinicians and physicians who are ready to adopt and use the technology, and then also have patients who are willing and eager to have access to their healthcare and willing to try a new way to access that healthcare. So again, thank you very much for joining us on this panel.
Thank you. Thank you again.
Jasmine?
Thank you, Dr. Charles Sperling and Kara, for those important lessons. This is really a great transition to our next discussion. The COVID-19 pandemic also laid bare the racial, ethnic, and socioeconomic inequities of the U.S. public health system. I'd like to introduce my colleague, Lindsay Vinia next, Cardiovascular Working Group Manager of the Alliance for Patient Access, to walk us through this conversation with our next two panelists.
Thank you, Jasmine. I'm happy to be here today for an incredibly important conversation and fortunate to be joined by Dr. Rachel Bond, System Director of Women's Heart Health at Dignity Health in Chandler, Arizona, and Dr. Keith Ferdinand, Professor of Medicine at Tulane University School of Medicine and Tulane Heart and Vascular Institute in New Orleans, Louisiana. So welcome to you both.
Welcome.
I just also want to note Dr. Ferdinand is also a board member of the Alliance for Patient Access and such an active member of our working group, so we're so appreciative of his efforts. Our discussion today, and it could be its own webinar, it centers on the critical problem of racial disparities that we know are occurring during this pandemic. And as everyone knows, about a month after the national emergency was declared, we started to see COVID mortality data that was broken down by race and ethnicity, and it was alarming. So an early CDC sample of about 580 people hospitalized with confirmed cases found that 33% of patients who were Black in a population sample had COVID, where even just that population was 18%. White people made up 59% of the same population, while only 45% of those individuals were infected. So we know that this pandemic has been laid over a foundation of inequality. And as we just heard Jasmine mention, that includes employment and housing and access to high quality doctors and care. So these facts are all shaping how communities are experiencing this crisis. And so we want to talk a bit about why that is, and then perhaps what policies can really try to change it. So I want to start with you, Dr. Ferdinand. We've heard you often compare the lasting impact of COVID-19 and what it will mean for the Black community to Hurricane Katrina. And can you talk about why that's such a spot-on comparison in this case?
Yeah, we've actually published commentary related to that. On August 29, 2005, the levees broke, 1,500 people died in a relatively small city. And the people who could not get out when the mayor ordered evacuation on August 28th were the 40% of essential workers, that's the term we use now, who didn't have an automobile. And subsequent to that, people with diabetes, heart disease, and other conditions died exponentially at a higher rate. Fast forward 2020, COVID-19 pandemic, and it's some of the same populations who could not get early testing because they don't have an automobile, did not have an identifiable source of primary care, so presented to the emergency room in the throes of a respiratory distress, and had an increase in comorbid conditions, including diabetes, obesity, hypertension, and heart disease, chronic kidney disease, and chronic lung disease, all of which are directly related to an increase in mortality. So what it shows is that the persons who are at the bottom of our society get hurt the worst, whether it be a so-called natural disaster or a pandemic.
That's right. And, just a level set, Dr. Bond, the numbers keep rising. The pattern remains the same. Can you talk to us and set the table a bit about the latest figures that we know and your sort of take on their significance?
Absolutely. So when we look at the Black Americans overall, we know that they comprise about 13% of the U.S. population. However, they account for about 23% of the total number of deaths from COVID-19. To date, as of today, we're at about 166,000 deaths when we look at the absolute number out of the 5.1 million that are actually infected with the virus. And we know that if we even really focus in on the top 5 states, for example, that have the highest rates of COVID-19, that being California, Texas, Florida, New York, as well as Georgia. Just using New York as an example, as it was the original epicenter, we see that the Black community comprises about 20% of the population. However, they account for about 45% of the number of deaths from COVID-19. And similarly, in a state like Georgia, which does have a larger population of Black people, we know that roughly about 30% of that population is African American. They as well account for about 45% of the number of deaths from COVID-19. Bringing it back to New Orleans and Louisiana, as Dr. Ferdinand very nicely highlighted the comparisons, we see that similarly, there's about almost 50%, if not even earlier stages, a 70% higher likelihood of African Americans dying from COVID-19 compared to their white counterparts. And I think that what this really highlights is the significance that these are vulnerable populations, and we really truly need to focus in on these vulnerable populations, be it through medications, but most importantly, prevention. And I think that when we think about prevention right now, our largest form of prevention hopefully will be a vaccine. There are some studies obviously showing that it is favoring the vaccine, at least data is favoring. And I think right now we need to be aware that the vaccine must work for everyone. And it's imperative specifically because we have the Black community that's dying at about 6 to 7 times a higher rate than their white counterparts. And to that same point, it's not just adults. We're also seeing that even children particularly Black and Hispanic children are being hospitalized at much greater rates than their white counterparts. So it's absolutely not only a scientific necessity, but it's a moral imperative that we focus in on these vulnerable populations.
And so with that in mind, we have a deadly virus, but we have equally as deadly structural racism. And, you know, where in the past, that's a very obvious thing, like social segregation leading to lung problems because folks might be in more polluted areas. There are more nuanced sort of forces at play right now. Can you talk a bit, and this would be for Dr. Bond, but also Dr. Ferdinand, can you talk a bit about what it means for this community to have lower quality insurance, lower quality hospitals, other sort of causal links that you've seen?
Absolutely. And I think when it boils down to it, we know that the big overall hinging cause is systemic racism, right? We know that racism in of itself leads to poor quality and poor quality of care. It leads to a disadvantaged group of individuals that are going to be more prone to chronic medical conditions. It leads to higher levels of social determinants of health that factor into their long-term overall health. And what I can say is that what we at least have seen with this very novel virus is that the Black community as well have a tendency to be the essential workers, right? As Dr. Ferdinand used that term, essential workers such as healthcare workers, such as public health workers, meaning that they don't have the advantage as others perhaps to take off of work because they are so needed and absolutely necessary. And with that, they're more prone to this virus, but with that as well, they may place themselves at a higher risk of having this particular virus. They may not have as flexibility in their job, either be it security or even the ability to take off from work. So I think that when we think about COVID-19 as a whole, it's absolutely shining a light on a lot of the disparities that we're seeing, but it all boils down at the end of the day to the systemic racism that we're seeing in this country.
Yes, another panel I was on recently, folks are talking about intergenerational families living together and how, you know, for folks who are essential workers and don't have the option whether or not they can quarantine safely in place, they're exposing not just themselves, but other loved ones who may be impacted. So it really just compounds. So we're hearing that this virus is laying over this infrastructure where people of color have been living with these disparities that affect their ability to really deal with both the economic crisis and the health crisis. And we look at Black Americans, they're already at higher risk, as Dr. Bond said, for diabetes, obesity, high blood pressure. Those make you high risk individuals for COVID. Can you both explain the connection of these risk factors to the virus to help folks better understand why this is such a high risk population?
Well, I actually think the structural problems that we discussed may be as important as the risk factors. Now, age is the most powerful predictor of mortality or dying. And the risk factors, diabetes, obesity, heart disease, underlying chronic kidney disease, are clearly factors. But when you look at the levels of hospitalization and death, they are greater than that would be predicted by the risk factors alone. So those structural problems, not having an identifiable source of primary care, not having insurance. And what that means is you stay home, waiting until you can't do any more than go to the emergency room. You then present later on in the stages of your disease. You have higher mortality the later you present. That then predicts those problems, along with the essential working problems that we talked about. You have prisons. You have people who live in multi-generational homes. So you have to look not only in the Black community, you see it in the Hispanic community, in certain Native populations and immigrant populations, where you'll have the grandmother, the grandfather, the great uncle living in the same home with the child. As the children start to go back to school, as they start to go back to colleges, they're going to come home to the same house where a person who may be in their 60s or 70s with diabetes and heart disease reside. So I think we're in big trouble. And I think we're in big trouble because we're not going to be able to eliminate this disease until we identify, contact trace, and isolate. And it's very difficult for some disadvantaged populations to do those things.
Dr. Bonds, Sorry, go ahead.
Yeah, absolutely. I completely agree. And to that same point, we know that, yeah, absolutely, these chronic conditions are placing these patients at a higher risk for severe illness. However, we know that when these chronic conditions are not well controlled, they actually are at a much higher risk, right, for these severe illnesses, including mortality and death, for example. So I think it all does boil down to that access to, right, good quality and affordable healthcare, and making sure that they have access to a primary care physician, that they have the flexibility of seeing their doctors during this pandemic, be it with telemedicine or other ventures that we can potentially hold and utilize. But I do think it's imperative and absolutely important.
And I want to pick up.
I stayed up at night, Lindsay, for days trying to figure out what should we call this present condition. And I came up with the term sentinel. Sentinel events are what the Joint Commission does when it evaluates a hospital. If you have instruments left in patients during surgery, patients who fall out of the bed and break their hip, these are the type of things that show really poor quality. I think the disparities that we're discussing related to COVID-19 are clearly distressing, but it's a sentinel event in that it shows that we have long-standing, unacceptable disparities in healthcare. It's a scar on the healthcare delivery system in the United States.
And with that in mind, I want to pick up on a point that Dr. Bond raised too about, the struggle to manage a chronic condition like cardiovascular disease. I think that when we had our original call in April, the term long hauler effect had not really been in a term that folks had been used to, but essentially what that means is, there are patients who are experiencing not just symptoms of the original, viral infection, but are developing these other related sort of inflammatory diseases, rheumatoid arthritis, others for months later afterwards. So even though they technically are perhaps virus free, they're dealing with related comorbidities. And so I'm just wondering, knowing what we know about perhaps communities of color and cardiovascular disease being an inflammatory disease itself, if you were looking in your crystal ball, what it means for the healthcare system, knowing that we likely have this long hauler effect coming down the road towards us.
Well, I say that a lot.
One of the things we're going to have to do is make sure we have that universal access, because people are going to need care. It's going to be a defining point in their lives where they may have been healthy before and now they have chronic disabling illness.
Mm-hmm. And Dr. Bond?
Yes, and to that point, again, we don't know quite yet what the long-term effects of COVID-19 and a severe illness, even from that, will look like. What we can say is that it does lead to a robust inflammatory process that absolutely is affecting the heart. But what does that mean in the long term? It's too soon for us to say. As you made mention, a lot of the inflammatory conditions, such as rheumatoid arthritis or even lupus, for example, they do actually disproportionately affect usually women, but more so women of color and people of color. And we know that in of itself likely will place our communities of color at a much greater disadvantage when it comes to any potential inflammatory long-term effects that we see from this virus.
And so, vaccine or not, it sounds like the effects of COVID are going to be with us for a long time. So let's talk about some policy solutions. Let's talk about how this is going to require a wraparound approach. I would say, Dr. Ferdinand, can you talk about some solutions you think would help in the short term for communities of color?
Well, first of all, we need to continue to test, but we don't need to test patients who are already ill. We need to identify people who are early in the process so we can contact, trace, and identify. As kids go back to school, we need to make sure that the environment in which they're entering has social distancing, the ability to wash their hands, that they wear a mask, mandated, not just asked, and that they're able to then go home into a situation where they're not bringing the virus back into the home environment. We're going to need community health workers and others who are going to help the community to identify disease early and get immunization for influenza. Influenza is going to built on the platform of COVID-19 during the fall and into the winter. And we already have anywhere from 12 to 50,000 people may die from influenza. That's going to build on the mortality of the death rates related to COVID-19. So we need to address those. And in Louisiana, as you know, we have a health equity task force in which we specifically look at those populations, African Americans, Hispanics, Native Americans, and Asian population. Here in Louisiana, it's mainly people from originally Vietnamese. And we try to identify in culturally appropriate, literacy appropriate language, ways in which we can educate patients about the need to get testing, to continue to use hand washing and social distancing, wearing masks, and seeking care, not just related to COVID-19, but immunization for influenza and control of cardiovascular risk.
And I'm glad you brought up the task force because you were asked to serve as a member of the governor's coronavirus task force. And that is a tremendous opportunity, but they're also very lucky to have you. What can you tell us a bit about, some of their proposed solutions? I think Louisiana was one of the only places in the country, perhaps because you were hit first, because after Mardi Gras, et cetera, to really suspend prior authorization through legislative action. Can you talk a bit about what that task force has identified as things that might be helpful?
Louisiana is doing several things. One is removing the need for a driver's license in order to be tested. As I mentioned, related to Katrina, when they said everyone should evacuate, 40% of people who were service workers didn't have cars. And many people who are undocumented immigrants will get ill because they don't have a license to identify themselves to get early testing. So remove that from the platform. Then target early testing using mobile centers, not just drive-throughs in the suburbs, because now you want to make sure that people who live in the inner city, who may not have cars, who may go to places where other persons who have that type of transportation will go for testing, they can walk in and get the testing that they need. Also remove those barriers to insurance. Although we're in the Deep South, our Governor John Bell Edwards did the right thing and expanded Medicaid. And we know even before the pandemic, those counties that expanded Medicaid and included the Affordable Care Act, that's part of expanded Medicaid, actually had lower mortality, lower death rates than those counties that didn't. So that kind of set the table that although we were hit with Mardi Gras, where 200,000 and 300,000 people came from all over the world, and we don't know where it came from exactly, but I'm sure that the coronavirus came in during that period. We already had in place at least that expanded Medicaid base, and now we built on the early testing, the appropriate cultural languages going out into the communities to identify people and help them understand the need for testing, contact tracing, isolation, and to build in those messages in terms of social distancing, hand washing, and wearing the mask.
Thank you. We have about 5 minutes left, so I want to jump ahead to the last two questions because, again, this is such a wealth of information. This is a problem that's been exacerbated by pre-existing issues. We've talked about that. But we also know that this is something that goes so deep in terms of internal biases that everyone has. And I came across a astonishing statistic recently that was 50% of white medical students and residents believed that there was a difference, a biological difference between how white and Black patients experience pain. And we know that's wrong, but somehow 50% of those educated people made that conclusion. And so, we had heard from Dr. Kuntz back in April when he joined the call series about how there really is a greater need for representation in medicine. And so I just wanted to hear from you, perhaps, Dr. Bond, if you want to start. How do we address these problems with our young doctors? How do we break this cycle? Do HBCUs have a greater role? How much more resources can we give historically Black colleges and universities so that they can put more doctors out into communities of color? What would be your response to that?
So this is actually an area I'm extremely passionate about in terms of really improving the pipeline and diversifying the field that we're in, particularly even the cardiovascular field where we have a very low rate of underrepresented minorities. I think to your point, it really does start even as early on as, if not even college, even before college, right? So high school students, when they're starting to really think about going into the field of medicine. And how do we engage them? By showing representation, right, in our field. So showing physicians that look like myself, look like Dr. Ferdinand. And also, not only that, but we want to also educate our clinicians that are not underrepresented minorities. And a lot of that is, I think, tweaking perhaps the education that we do receive even as early on as medical school. So you had brought up, or we potentially will be bringing up the Tuskegee syphilis experiment, for example, and that's a really pivotal, obviously, experiment that had brought up, at least brought to light, significant disparities when it comes to race in terms of the treatment that we were providing or not providing to individuals, really. And it led to a large degree of mistrust in the African American community. So I think that starting in medical school by providing lessons, historical lessons on the disparities and the history and centuries of disparities that we've seen across the healthcare field, but more importantly, perhaps allowing our clinicians that are not in the underrepresented groups to really have more of an understanding, to be more empathetic towards these patient populations will probably be the way, I think, to make sound change, because we not only want to diversify our field, but we also want to make sure that our colleagues are partnering with us to improve the overall care of these particular patients.
And great answer. We have about 2 minutes left, so I want to look ahead also and talk about the vaccine. Dr. Bond mentioned Tuskegee and the deficit of trust that exists, rightfully so, in these communities. Dr. Ferdinand, can you close us out by giving a final thought about what it means for communities of color and the vaccine dissemination when that should occur?
Well, the task force actually discussed this morning. We talked about the fact that there is a underlying distrust, and it's not because people are ignorant, because they have been afforded the opportunity to feel the pain of bias. I think what we're going to have to do with the vaccine is not just make sure that it's out in warp speed, make sure that it's safe and effective. And in terms of bias for our practitioners, I'm here at Tulane. The Association of Black Cardiologists nationally has always said, and I agree, that everyone should be treated to the best of our ability, regardless of their race, ethnicity, sex, gender, social class, or geography. And if any provider is not doing that, he or she is not doing the right thing.
Thank you both. As advocates, you've given us a lot to not just think about, but to work for and work towards. So, when you think about effective public policy, you have to know who you're trying to help. And I think this group that we've all been talking about is the priority. So let's just keep using our collective voices to raise awareness. And I just want to thank you for your thoughtful commentary today.
Thank you.
Thank you.
Thank you so much. The pandemic brought about a lot of changes, some good, like telemedicine, and some bad, like people not seeing their doctors. Exacerbating that challenge, COVID-19 amplifies risk for people already at highest mortality risk, including cardiovascular and diabetes patients. The task of finding creative ways to treat these and all high-risk patients fell upon healthcare providers and insurers. One approach, implemented by health insurers, involved reducing existing access barriers to care, such as lack of telemedicine, reimbursement, utilization management protocols, and high cost sharing. To discuss how health plans have facilitated patient access during the pandemic, I'd like to welcome my colleague, Ryan Gooch, Executive Director of PACH.
Hi, everyone. My name is Ryan Gooch. I'm the Executive Director of the Partnership to Advance Cardiovascular Health. And I want to start by saying that, one great thing about the era of Zoom is that we're able to bring together clinicians from Louisiana, California, in this case, North Carolina and Mississippi. And so today, I'm very pleased to welcome PACH's president, actually, Dr. Dharmesh Patel. Dr. Patel is a cardiologist at the Stern Cardiovascular Foundation in South Haven, Mississippi. And then someone new to PACH. I'm very excited to have her on with us today, Dr. Anne-Marie Navarre, Associate Professor of Medicine at Duke Clinical Research Institute in Durham, North Carolina, just down the street from me. So happy to have you both here. Thanks so much for joining us. I know that you are both incredibly busy. To get started, I want to level set for our audience because when we're talking about utilization management, those are two difficult words to say, and it can be difficult to understand, what they even are. So Dr. Navarre, just to level set for everyone, can you talk to us about what utilization management is for you as a clinician? What is prior authorization, non-medical switching, step therapy, real quickly?
Sure, it's a great question, and thanks for the opportunity to join everybody today. So there's really two different pathways that we think about for utilization management issues. The first pathway is around procedures or access to different tests or healthcare. So oftentimes, a lot of that utilization management happens behind the scenes. So I order a certain kind of scan or a stress test for a patient. The insurance company then reviews it to see whether or not it's appropriate, and if so, are they going to pay for it? Sometimes that happens all automatically, and the test is just approved and paid for. Other times it requires sort of a physician insurance interaction where we have to sort of justify the test. The same thing happens for surgeries, imaging procedures, and then is sort of in the same domain as what is covered for visits. Prior authorization, though, are things that you can sort of implement before the test actually happens. This is sort of different than what we've seen in terms of broadening of reimbursement or payment for things like telemedicine, which weren't as commonly covered pre-COVID. The other side, though, of utilization management is really about medications. And there's two different tools within a utilization management spectrum that insurance companies use to try to minimize how much they have to pay for medications at a population level. So the first is prior authorization. So that is making sure that certain therapies are restricted to certain types of patients, or that you have used cheaper or more generic therapies before you get to the higher cost therapies. Again, that often requires pretty complicated paperwork for physicians to go through, where we have to document why we're choosing a drug, and then for certain medications, for example, cholesterol medicines called PCSK9 inhibitors, we have to document what therapy somebody's been on in different labs. The other side of utilization management is what the patients actually see, which is the copay. So copay is actually a tool that health insurance companies use to try to steer people towards certain therapies that are perhaps better to the bottom line for insurance companies. And so you'll often have like tiered pricing where the more expensive therapy costs more than a generic. And then within that, the third thing would be to talk about non-medical formulary switching. And so this is where insurance companies have like a set list of medications that they cover, but there's sort of a preferred one within certain classes. And often that preferred medication is cheaper than other medications, at least to the patient in terms of a copay. Where it becomes challenging is that often the companies, and this includes not just private insurance companies, but Medicare and Medicaid do this often as well, will renegotiate with pharmaceutical companies the cost of medications and then change what the default medication is. And sometimes patients don't find out about that switch until they go to refill their medication and see that their copay has jumped up. And if they don't know that there's a formulary alternative, they didn't get a letter in the mail, their physician wasn't informed, they'll often end up either paying more or just stopping their medication entirely. So it can cause a significant number of treatment interruptions. So these were all things that were kind of in the pre-COVID era, and I think we'll talk about what's happened post-COVID.
Thank you. Incredibly well spoken. I couldn't do it any better than that. I want to ask Dr. Patel, when we talk about utilization management, we couch it in what's going on with cardiovascular disease in the country. So again, to level set, for folks on the call who may not have as deep an understanding of kind of the public health aspects of cardiovascular disease and what's happening within the population, can you give us your take on whether or not there's a crisis in the country when it comes to cardiovascular disease, and cardiovascular comorbidities.
Thank you, Ryan, and that was very nicely spoken, Anne-Marie, about the utilization management. But absolutely, Ryan, your point is extremely well taken. Cardiovascular disease to an extent is an epidemic. We have essentially the number one cause of death in America is cardiovascular disease. In fact, if you talk about it from a monetary standpoint, it cost $555 billion in terms of US healthcare in 2016 and expected to be up to $1.1 trillion by 2030. And that accounts for up to 20% of the GDP of America. Yes, this is ultimately a crisis. And, cardiovascular health, we have misperceptions. It's the number one cause of death in females. Heart disease is one in 3 females dies of cardiovascular disease. 1 in 33 females dies of breast cancer, just to give you an idea. And the AHA gave a very nice goal at the end of 2020. The goal was to improve cardiovascular health by 20% and reduce cardiovascular mortality by 20%. But it's very, very sobering to say that that actually did not happen. When you talk about cardiovascular disease, actually we reduced cardiovascular events by up to 60% in the last 6 decades or so. However, in the 2014 to 2017, there was actually an increase of 4% in terms of cardiovascular events. And I hate to say this, but unfortunately, in the last few years, we have actually done worse. As a nation, the amount of people dying from cardiovascular disease is actually increasing. And the reason for this is it's ironic. It's actually a dichotomy. Here we are talking about the latest and greatest therapies, yet as a nation, we're having more increased cardiovascular events. And, one of the reasons is there's more disease, there's other factors that come into play. And, I was just seeing a patient just now before we took this conference, and, things have changed. And I'd love to hear what Anne-Marie has to say. But now when you see patients in a room, there's not just the doctor or the provider and the patient. There's 3 people in the room. There's the provider, there's the patient, and also there is this thing called utilization management or the insurance company, or the fact, will the patient truly get the medicine that I would like them to be on? Will that patient have met their deductible? There's all these real practical concerns that we've not had to think about, but I think in today's world of medicine, we're having to juggle treating the patient. What is the patient able to take? What patients will the patient be approved for in terms of an insurance company? What is their deductible? There's so many other factors now that come into play. And I personally think they were just highlighted when the COVID pandemic came. During the COVID pandemic, certain states like Louisiana did ban or stop all PAs during that emergency time. It basically highlighted something that I personally think should be going on COVID, pre or post-COVID. So those are my thoughts about how heart disease has come in the last few years. Unfortunately, we are on the way up.
Well, and I remember an article that was published in the Wall Street Journal last year, and the author, the reporter said, a lot of heart experts, which I would consider you both heart experts, say that there needs to be new tools and approaches to combat this crisis that we see in the country. But it gets to access, right? I mean, if we have these tools and approaches, can patients actually get them? And so my question to you both is, between you, you've got 30 plus years of medical experience in your career. I'll start with Anne-Marie. Do you think that UN protocols have gotten more or less restrictive over your career? And then Dr. Patel, you can follow up.
So I think the answer is they've gotten more restrictive. The opportunity to make them easier through automation or using the electronic health record just has not come to fruition. And so many of us are still spending lots of time for which we are not reimbursed filling out paperwork. I just got an email fax where an insurance company is trying to change one of my patients from a high intensity statin to a low intensity statin because presumably they've negotiated a different rate. These drugs are generic, cheap, and really rather than making it as easy as possible for people to be on therapy, all of these little steps impact patient adherence, impact prescriber willingness to change therapy. It would be much easier for me to default to do the wrong thing for this patient. Instead, I'm going to have to call the insurance company and justify why they need to be on an $8 a month generic instead of a $5 a month generic. The other thing that's happened is, on one hand, it's really great. We've had a lot of wonderful innovation in the cardiovascular space with a bunch of new therapies that are developed, both in cholesterol lowering, but also in heart failure with drugs like Entresto or ivabradine. And unfortunately, these therapies, because there's so many patients with heart disease, the potential cost of these therapies, if we treated all of the patients, is quite high. So rather than try to figure out who should we treat, who's going to benefit the most, and thinking about cost at a population level, what's really ended up happening is we as providers are facing really high barriers in terms of paperwork and rejection rates for these new therapies. Patients face extremely high copays. And that's essentially been the way that these therapies have been rationed. It's not rationing by targeting those who are going to benefit the most. It's rationing by roadblocks. And I don't see that getting better. And we've also seen increasing barriers and prior authorization problems happening with tests that we order, being things like stress tests or echocardiograms. On one hand, this is good. We're trying to reduce waste and we're trying to minimize the population health spend. But the end result from the provider perspective is often a lot of work and frustration. And from the patient perspective means that care is interrupted and they're not able to stay on the therapies that they need to be on.
I think that's excellent, Anne-Marie. Your point is so well taken. We are having to use prior authorizations, et cetera, to try to get the therapies, but it's basically a game. Half the time they haven't met the deductible, they quote are out of network, and then they go back and you refill it on January 2020. You have to redo the whole thing again. Let's be honest. I mean, prior authorizations cost this country $23 to $26 billion a year. Both of us as providers, I think you would appreciate, we've had to have more staff just to get through the red tape. That is so disheartening. And on top of all that, I can give you an example. Like, for example, PACH recently was able to approve the PCSK9s in Mississippi. This is June of 2019. We had an FDA approval of this groundbreaking therapy in 2017, if I'm not mistaken. So what were patients who had high cholesterol doing for the last 2 years? And, we can discuss, well, it takes time. Well, unfortunately, we know from data such as from the circulation qualities and outcome cardiovascular events that patients who did not get the PCSK9s, they had an increased risk of 16% of myocardial infarction and further events. So yes, time does matter and promptness matters. And it's very frustrating because we can talk about so many different classes of medicines, glucose lowering medicines, heart failure medicines, cholesterol lowering medicines, blood pressure lowering medicines. And it's like hitting your head against a dead wall. We're doing an injustice to our patients. We are all on this call because we're patient advocates. And it's unfortunate because the people that need it the most are not getting the FDA approved therapies, which have been proven to further reduce cardiovascular events.
I'll just add one thing too to this, which is I think that one of the challenges that we see, or one of the consequences that we see of these utilization management practices, is it really discourages providers from even writing the prescriptions at all. So we did see some of the companies drop the price for PCSK9 inhibitors. The prior authorization process actually has become way easier than it used to be. But because it was so hard initially, providers are Pavlovian, and many of us learned that it's too much of a hassle to prescribe, and it's going to take too much time. And so we haven't seen an uptick in demand. A lot of cardiologists aren't starting to prescribe these therapies. And I think it has stifled innovation, not pre-development, but the sort of last mile after we have a breakthrough therapy, we're not able to achieve because we just don't even want to prescribe the therapies because it's too much hassle.
So some of our audience members may say, what's this have to do with COVID? So let's talk about what happened during the public health emergency and the national emergency. So and I think we have a slide to show this. So once the public health emergency and the national emergency was declared, there were a number of kind of dominoes that fell. You saw 1135 waivers being issued by states to CMS. You saw blanket waivers being issued by CMS. And then we saw the CARES Act passed. And as a result, private and public payers were able to shift some of their prior authorization policies. And the bullets you see here do not encompass all of the shifts, but there's kind of three buckets that public and private payers changed. One, I would say, has to do with COVID-19 testing and treatment. cost sharing, and prior authorizations, in particular for testing, were waived. Treatment, it depends on your plan. The second major shift we saw in terms of utilization management services has to do with telemedicine. We heard a lot about that in the first panel. There was this massive uptake of telemedicine. The floodgates really opened for telemedicine. And then the third has to do with medications generally. So prior authorizations and grace periods were extended. Patients were allowed to refill their medications early or change to a 90-day supply. And existing maintenance medications were, the prior authorizations for those medications were waived in some cases. And generally speaking, this is kind of true for most large health plans. So I bring this up because in our call series, which is discussed in the report that was released this week, we had the Vice President of Clinical Affairs and Strategic Partnerships, Kate Berry, from America's Health Insurance Plans, which is the trade association for America's Health Insurance Plans, AHIP. And Kate was talking about all of these different steps that plans were taking to decrease barriers to care. But what is kind of shocking to me, and I'm curious your thoughts on this, Dr. Patel and Dr. Navar, is, wasn't this action, which took place immediately, a tacit acknowledgement that these protocols get in the way of appropriate care? I mean, what is your take on that?
I suppose I'll start off. Unfortunately, there's been a lot of bad with COVID-19, but I think there's also been some good. I think this clearly shows, does it really need to have a COVID-19 pandemic to show that you can do these simple implementations which actually improve patient access in terms of therapy? And what about before COVID? Let's go before that. I mean, this may be the new. Maybe Zoom meetings is the new. Maybe not going to offices anymore is the new. But the point being that I think we have all learned to adjust with the COVID-19 pandemic, and all these simple implementations are things that I would say should really have been going on before. I think the COVID-19 truly just simply highlighted patients who had cardiovascular disease, who are probably more prone to having COVID, let's pretend. And, I think it's really proves the fact that some of this red tape doesn't necessarily need to be there.
Yeah, I applaud the changes that have been made. I think that they're important, but the reality is you can't put a Band-Aid on a broken system, and that making it better is still not good enough. So even still, despite these changes, if I want to initiate somebody on a new therapy, I still have to go through the same prior authorization requirements as before. But it's harder during COVID, because if I'm doing a telemedicine visit, I may not be able to get the labs that I need within the time period needed to prove that somebody's cholesterol is high enough. I also am struggling to just organize. I don't have a clinic and a telemedicine visit where I'm sitting next to a nurse who's next to a fax machine who can help me do this. So the coordination of that has been really impeded as well. So there are things that the COVID pandemic has highlighted. I think these changes do show that there probably is a lot of room for improvement. But I'm not sure that there's that much of a desire on the part of the payers to actually make it easier, because the harder they make it for us to prescribe expensive therapies, the more money that they save. And let's face it, the non-medical formulary switches, particularly when you're within generic medications that don't cost that much money, are largely to maximize the profit that are made through discounts and rebates, not because it's a better therapy for one patient or another. The other thing that I think would be remiss to not talk about is all of this is presupposing that everybody has insurance and that it's not changing. And during the epidemic, we've seen massive amounts of unemployment. People are losing their insurance. They're also losing their ability to pay high out-of-pocket costs that they previously been able to pay. So, realizing that we have problems for people who have what we would consider the best health insurance, meaning commercial insurance that they're getting through a job. Can't even imagine. It's sort of a non-starter to talk about some of these expensive therapies for people who are uninsured or underinsured.
So listening to the first panel, Dr. Kara and Dr. Sperling, Dr. Charles, we're hearing that we've seen this spike in cardiovascular death as a result of folks having COVID phobia, not going to the hospital or to their normal doctor's visits. You know, you have these mandated lockdowns, new hospital and clinic rules, what you're talking about, Dr. Navar. And you'd think that as a result of all of that, you know, there would be some more leeway or liberty for clinicians to practice to keep their patients healthy. But what you're telling me is that's not happening.
Yeah, we'd like to be in a system where population health matters, but that's not the system that we're practicing in. Most of us are still caring for patients, and most patients are receiving healthcare through fee-for-service health systems that make money for doing things to patients. And the medication model that our patients are living in is predicated on a number of middlemen, including PBMs and pharmacy distributors and insurance companies themselves making money on the prescriptions. We don't make money for preventing heart attacks, but we make a lot of money when we treat one. So I think the fundamental incentive of our healthcare system fails to promote an atmosphere of prevention. And that's probably a frame shift that until we get there, we're going to be sort of stuck in this tension between population health and prevention and kind of a capitalist fee-for-service health system.
Dr. Patel, can I ask you, I mean, we have some specific examples of switches that have happened during the emergency. Can you talk about that a little bit? Yes,
I want to just piggyback on what Anne-Marie said. You know, as providers, unfortunately, sometimes some of the latest and greatest therapies are not generic. And so as providers, you know, we want to always do the best for our patients, but because these medicines are not approved by insurance companies, or they're, quote, lagging by 2 or 3 years, maybe that's just a ploy, you know, we are not able to give our patients the best therapies out there. Would you use an iPhone 5 if you had an iPhone 11? It's a great example. And to your point, Ryan, it was disturbing. You know, one of the largest PBMs in the country during the time of the COVID pandemic, 30,000 patients were affected in terms of a glucose-lowering medicine, canafloxacin, which has helped use an SGLT2 inhibitor, which basically decreases sugar or sugar levels in patients who have heart disease and diabetes. Another example is evolocumab, a PCSK9 inhibitor, which, you know, 30,000 people were affected because in the middle of the COVID crisis, they had a medical switch. And, you know, I think these 30,000 patients were left basically hanging during this difficult time. They may have not been able to see a provider. They may have not been able to get through on telemedicine. And these people are left hanging. And I think that's something that's really not acceptable on any level. And, you know, it was very concerning to see that this was highlighted during the pandemic. You know, simply just changing the switching or the non-medical switching during that time, I think is really not good for patients and for anybody, to be quite frank with you.
So I have to say, you know, listening to the two former panels, what we're doing right now, it seems, is we're digging into questions that have been highlighted, you know, by the COVID experience. They've got a lot of media attention from the COVID experience, but they've been around a lot longer, right? You know, you've almost answered this already, both of you, but can you both just comment on incentivizing prevention culture instead of a break and fix culture?
I'll go first. You know, the bottom line is this: we know that for every dollar even the American Heart Association said this, for every dollar you spend now in prevention, you'll save $3 later on. You know, I have to think strongly about this. I do preventive cardiology. I think cardiology primarily is a preventable disease state. And with that in mind, if we are able to give our patients the appropriate therapies, and look, I respect the fact that there is a cost issue. I understand that. You know, there are cost health analysis and other things, but at the end of the day, we should at least be given certain FDA-approved medicines which really improve mortality, morbidity in our patients, stop the risks of strokes and heart attacks. The number one cause of disability in America today is stroke. Something as simple as blood pressure checks and lowering cholesterol to reduce myocardial infarctions. And I'd like to hear what Anne-Marie said, but this is such an exciting time in cardiology. Even in the last 2 or 3 years, there's been groundbreaking medicines in the treatment of heart failure and heart disease and congestive heart failure and hypertension and lipids, anticoagulation and thrombosis. It's such an exciting time, but I feel as providers, sometimes we have our hands in handcuffs. We just can't do anything as patient advocates to help them further reduce cardiovascular events.
I couldn't agree more with what my colleague just said. From my perspective, if I zoomed out, the question of how do we get to a place where our health system cares more about prevention? We've been talking about a transition to value-based care for a long time. We've yet to see it, but in North Carolina, Blue Cross Blue Shield has been rapidly increasing the number of people who are under sort of more value-based care contracts where you pay for the total patient, not for the individual things that happen. I think a movement towards more of that is going to help. There's other things that we need to see on the policy level, better transparency in drug pricing, so that and better negotiating power for Medicare and Medicaid to get better prices for our patients. I think there's some technology solutions that are going to help us do a better job at getting the therapies to our patients and then allowing them to stay on the therapy, promoting adherence, automatic refills. We should be able to auto-populate most of our prior authorization forms. So, within the system that we're in, using the EHR and other digital technologies to improve our patients' access to therapies as well as how much they stay on it. And then the bottom line is we need to continue the trend in the United States of increasing access to health insurance for everybody. The care of our population and the dramatic tidal wave that we've seen in cardiovascular disease will continue until we are able to take care of everybody the same. And it's incredibly frustrating as a provider to know that how I can treat my patient is going to depend on what insurance company is picking up their bill, and it shouldn't be that way. So I'm hopeful that that is going to change in the future.
So as we wrap up the panel, we'll be talking in this last few minutes about some of the takeaways from this discussion. And in the report and also in the calls that preceded this webinar, one question I asked our guests that came to the call was, what's your big takeaway from everything that's happened in the last 6 months or so? So I'll pose that to you too. I mean, what's your takeaway? And maybe, because I feel like there's a lot of big ones that you all have already touched on, but maybe I'd ask you to also kind of touch on what's the patient advocate or the clinician's role in this as we are advocating for policies that incentivize patient-centered care. Like, what do you think the role is for the clinician?
So my takeaway here would be COVID-19 pandemic has been a massive stress test to our healthcare system, and we have failed. And patients with cardiovascular disease are particularly vulnerable to COVID, but they're also particularly vulnerable to disruptions in their insurance coverage. And many of them are in need of therapies or tests that require prior authorization or other high copays that are limiting their access to therapies. I think that the COVID pandemic has highlighted that this is a problem, and it's particularly a problem for underrepresented minority groups and low income and rural Americans who just don't have the same resources as everybody else. As providers, there are things that we can do at the individual level, paying attention to out-of-pocket costs, being as persistent as we can to appeal rejections when things are rejected, and then doing what we can to educate ourselves about coverage of our patients so that we can prescribe therapies that they can afford. And then at a policy level, I think some of the efforts that you guys are doing in increasing physician participation, we should be advocating for our patients for things like better access to healthcare and better healthcare insurance coverage.
Dr. Patel, you can lead us out.
Yes, I think so. The bottom line is this: during this COVID pandemic and before the COVID pandemic, the provider has always been the patient's advocate. And from what my colleague just said, there's all these different barriers that have been in the way. I think we've shown that when these barriers are removed, things go much more efficiently in terms of patient care, electronically, or whichever target you use. So to me, the COVID-19 certainly showed the fact that we can practice medicine without a lot of these other barriers that providers and patients have, and do it very, very well. And, it proves again the fact, as I mentioned when I started this talk, the rate of cardiovascular death is increasing. We are losing as a country, as patients, as providers. Let's do something about it. Let's do something about being patients' advocates and removing these barriers which are really hurting us as a society, because at the end of the day, when a society is not productive, our country is not productive, and we as families and individuals certainly take a hit. So I feel that the COVID-19 just basically highlighted something that has been out there, and it shows that we don't necessarily need to do all these other things. I think treating the patient and being a patient advocate and removing the red tape is the way to go.
Well, thank you both, for everything that you do for patients, and thanks for joining us today. Really appreciate it. I know you are both incredibly busy, as all our panelists were, but we're very grateful for your words of wisdom and a lot to take away from this. So thank you so much for joining us.
Thank you.
Thank you.
So I want to say thanks to all of our moderators and panelists for an insightful discussion today. It's been, I feel so lucky getting to do this stuff, Jasmine, because we get to work with people that are at the top of their game, just as clinicians. But then on top of all that, they take on patient advocacy and policy work. And I mean, I just feel very, lucky to be able to work with them. And so just very glad that we could put this on and give them a voice, during this really interesting time that we're living in. But I wanted to ask you, as we wrap this up, we're all about takeaways. What's the big idea? What in your mind are the kind of key takeaways from today's conversations?
Yeah, I mean, as I was listening to everything, there honestly were so many take-home lessons, but clearly we have a window of opportunity here to implement meaningful policy changes that encourage patient-centered care now and for the healthcare challenges that will lie ahead. There definitely will be more ahead. And I really appreciated the quote that Dr. Sperling shared earlier by Einstein: in the midst of difficulties, there are opportunities. For one, telemedicine has proven to be a successful option for so many patients. Not only does it broaden access, but truly it has springboard continuity of care, which is so critical for chronic disease patients who require consistent follow-up with their healthcare providers to prevent mortality, but more importantly, manage their conditions optimally. Second, although racial disparities is by no means a new topic, it has received a fresh round of media attention that has really drawn the spotlight in healthcare discussions. We all agree with what Dr. Bond and Ferdinand said earlier, that it is a moral imperative that we focus on these populations. All of us in the advocacy community have to develop strategies to directly address and change the inequities communities of color face. And finally, utilization management. Like you said, insurers easing the standing utilization management barriers, in fact, acknowledge that they are barriers to care. And I think it will be very important for payers and our public health system to measure how these changes impact care. A common saying we can relate to here is what gets measured gets done. And we need to measure success and implement the successful changes indefinitely. COVID policies aside, Ryan, many cardiovascular and diabetes patients who are prescribed specialty therapies by their healthcare providers have to jump through enormous hoops right now to receive access to them. There have been various studies showing how that delay in care negatively affects their health. And now, when you add COVID-19 on top of that vulnerability, it has a compounded effect. Timely access to prescribed medicine should be a priority of the entire healthcare spectrum, especially for high-risk patients who rely on these life-saving preventive therapies. Chronic disease prevention, honestly, it's an investment in our future. And those are my key takeaways. What are your thoughts here?
Yeah, I can't say any better, but one thing that I would like to leave the audience with is some of the things, opportunities that exist like right now around some of the kind of three topics that we talked about. The most immediate one would be telemedicine. I think that's one thing that's really energized, not only the cardiometabolic space, but across disease states. And I will tell everyone that CMS, Center for Medicare and Medicaid Services, is actually working on new proposed rules for next year. And they will publish these rules soon, and there'll be a 60-day comment period for clinicians and patients to advocate for what they believe is working with telemedicine or not working with telemedicine. So number one, that's a great opportunity for folks that are interested to really push for policy change. Relatedly, there's a lot of state and federal legislation around telemedicine now, and there's lots of ways to interface with legislators to push that legislation along. Racial disparities, I think that our community, health advocates, have been aware of these problems for a long time. But we're in a unique moment in that, like you said, there's this fresh round of media attention on this, and especially in the health space. So I know that PACH stands ready to help the Association of Black Cardiologists and the National Hispanic Medical Association, and all these groups that are out working on this all the time. We are at this kind of unique point where the nation's attention is really focused on this. And something Dr. Ferdinand says a lot, you can't boil the ocean, but we know where the really sick folks are. And we need to target those populations, as you said. And I think that's, a key takeaway. And then lastly, utilization management. I mean, we've just gone through a national experiment, with utilization management, where these barriers have been lowered temporarily. And I think that we'll see papers from Dr. Anne-Marie Navarre and Dr. Kara and a lot of folks, looking at what happened during this period and how affected patient care. And in a lot of ways, as Dr. Patel said, this is whack-a-mole, with utilization management. I mean, there's always new interventions, new strategies, new therapies, new medicines coming to market. And we just have to be diligent about working on them when we can. And this experience really gives us another example to go back and say, this isn't appropriate if your goal really is patient-centered care. And so I think those would be my kind of three big things, I guess.
Yeah, absolutely.
Well, Jasmine, thank you so much for organizing this and bringing this group together. I really appreciate it, making my job a lot easier. And it's been fantastic. You've done an amazing job. I just want to say for everyone else on the line, we will be continuing this discussion and a number of other discussions on October 1st at our annual summit, which normally takes place in DC, but now it can take place in your home. It will be a virtual summit. We'll be talking about COVID. We'll be talking about the upcoming election and opportunities for advocates and where the health policy discussion kind of lies. We'll be talking about patient-centered care for those with difficulty with statins and statin intolerance and statin-related side effects, and a number of other issues. So if you're interested, you can actually click above on events and register for that now. And we would love to see you at that summit on October the 1st. So with that, I'll just say thank you, everyone. Stay healthy, stay safe. Have a great weekend, and be well. Thanks all.
Thank you.